Oh, good morning. So good to see you.
Good
I was just texting you.
Thank you. Yeah, sorry for all the tech challenges. Just sometimes the computer gremlin, like random. Sometimes the computer gremlins get us.
And it only happens when we're, speaking.
Of course it does. It's good to be with everybody this morning.
Yeah, we're just so happy to have you here. Thank you so much for presenting at our speaker series. I want to do a brief introduction. Of course, I've known Dr. Nunez-Smith for seems like forever now, from my time way back in the day at Yale. We've worked together for some time. But Dr. Marcella Nunez-Smith, if you don't know already, is the Associate Dean for Health Equity Research and CNH Long Professor of Internal Medicine, Epidemiology, and Public Health. She is also Associate Dean of Health Equity Research and Founding Director of the Equity Research and Innovation Center at Yale School of Medicine. Dr. Nunez-Smith's research focuses on promoting health and healthcare equity for structurally marginalized populations, with an emphasis on centering community engagement, supporting healthcare workforce diversity and development, developing patient-reported measurements of healthcare quality, and identifying regional strategies to reduce the global burden of non-communicable diseases. She is the principal investigator on many NIH and foundation-focused research projects. Most recently, she was called upon to serve on Connecticut Governor's Reopen Connecticut Advisory Group and serves as chair of the COVID-19 Health Equity Task Force in the Biden-Harris administration. So she wears many, many, many hats. I don't know how she does all of this. And we're just very pleased to have her here to talk to us today on her experiences as a health equity researcher. So Dr. Nunez-Smith, I will turn it over to you.
Thank you so much, Dr. Taylor. This is a delight. We, of course, miss you here at Yale, but it's just with a lot of gratitude that I show up here today. So excited to be able to continue to work closely with you, and of course, to spend some time with all the tremendous people who are part of your orbit and each other's orbits down at Columbia. My hope with the time today, I want to be sure if you see me kind of looking down, I'm going to try to keep myself honest with the clock so that there is time for conversation, right? And interaction and questions and just some dialogue. I do have a slide deck. I don't feel any particular compunction to get all the way through the deck. So might end up skipping around just a little bit depending on how it feels. I mean, it's a great gift to have a chance to reflect with all of you on the kind of the past 15 years of my career and my work. It's certainly right now it's I think a unique moment on that journey. You know, as Dr. Taylor said, I privileged to work with the governor and the state around COVID-19 policy, particularly as it affects marginalized, minoritized, and typically underserved groups and populations. And then to be invited to work with the Biden-Harris administration has also been tremendous, and have several hats there. One mentioned, which is chairing the COVID-19 Health Equity Task Force. I will say I'm very excited because we actually submitted our final report to the president just a few weeks ago. We could talk about that from the task force, but I also serve as a senior advisor to the White House COVID-19 response team. And so I think of that as a lot of now work and kind of the daily advising and decision-making around how we as a country respond to COVID-19 and make sure that there's equitable access to all of the relevant resources. So really happy to talk about all the things. I know everybody here is probably at different points on your own journey. I'm also, a spouse and a parent and all of that. And so really no topic off the table. So let me see if I can successfully share. I was kind of sharing earlier, again, these tech gremlins. So hopefully one of these will work. Let me know if you can see anything.
Yep, we see it.
Okay, great. Give me one sec. My apologies, because I think I did previously attempt at least to download this to share us a couple of steps. anything here works. Okay. And definitely feel free along the way to interrupt me, please. I will ask for somebody to keep me honest in that regard, because just how it's set up, I can't see if anybody has their hand raised or is opening their mic. So definitely just feel free to interject at any point. Good, decent visibility on these slides, just a thumbs up. Okay.
Yes, we're good.
All right. I have nothing to disclose. So, I think this is an exciting time, right, to be having conversations about health equity, and most certainly what our health equity research agenda should be. And so this is the
slides aren't advancing. We just see the first slide.
Oh, really?
Mm-hmm.
How do we solve for that? Give me one sec. Okay, maybe I'll try to stop share. So sorry, I don't really work with this device, which shows. Let's see.
And we have your slides too, so we can advance them for you if that's easier.
Oh, that might be better, because I'm not sure I'm going to figure out a way to remedy the tech challenges in time. Yeah, because on my screen, everything looks like it should share. If you feel comfortable sharing, that'd be great.
Sure. So Laura will pull those up for us, and then you can just let her know next slide when you're ready. Okay, can you see that?
Yeah, I can. Perfect. Thank you. All right, thank you. So, so where I was before, it was just kind of a rough framework guidance for our conversation today, and thinking about the moment we're in and where the opportunities are for really co-designing, I think, a health equity research agenda moving forward. I want to talk a little bit about building a research center. I'm physically at the Equity Research and Innovation Center right now, which is here at the Yale School of Medicine. Working with this team and so many amazing colleagues is deeply joy-making for me in the professional space. And I don't think there's any other way to do this work, quite frankly, outside of a collaborative framework. I spent a lot of time thinking about healthcare equity specifically. And of course, I think our conversation nationally has advanced considerably in these past couple of years, and making sure that now we're lifting up important constructs such as anti-racism in particular. And then the last is policy and partnership in the US government. And again, I may, just for that sake of time, given our late start, and with apologies, Laura, just even maybe briefly touch on some of the slides moving forward with an eye towards getting us to that important discussion and conversation time. Next slide. So I think you heard some of this. The introduction was very kind and gracious, so thank you for that. The way that I think about my time and activities in this space are probably in a few different buckets, which are shown here. Working as a researcher, I'm a practicing internal medicine physician too, and so probably if somebody asked me, what do I do for a living? I'm a physician researcher. And it's been great and a learning experience in so many ways to work on these various projects, and we will probably touch on them a little bit as we go forward. But also the policy piece, which I think is so important, and not true maybe in all spaces and disciplines and domains, but when we talk about health equity research, I feel like we have to be incredibly intentional of the policy implications and our policy partners. Really, every research project, what are we trying to change, evolve, advance? And for me, policy has been an important platform for that. And so it's been great to be part of a various policy partnerships and work, both locally, regionally, and nationally. And then just for the last two really quickly, just around mentoring and community service. I think those are really important aspects too for me, and are the things that kind of keep my well full in terms of making connection and hopefully contributing to difference making spaces. So I'm happy to talk about those things too, both in terms of mentoring others, but also as far as, why I encourage everybody to think about board service and volunteerism in different spaces. And that's just a list of some of the boards I currently serve on. All right, next, thank you. There are different definitions, so I'm not here to particularly put a stake in the ground and any particular one. This is what RWJF has posited. I put it in here. I won't read it to you. You can look at it yourself. That is that the work behind getting to this definition, I think, is the story to share. And so they actually engaged with Congress on this. They approached members of the House and Senate across party line to do a lot of formative work around where is a definition that we can move beyond maybe bipartisan to even like a nonpartisan space. And so I think when I first learned that, I was intrigued by that little nugget, and now understand fully why it makes sense to not kind of do even definitional work in a siloed way. And lifting up here, I think in particular, the language fair and just opportunity for all the testing that the team did then, that is what resonated with a lot of folks. So just keep that in mind, even as you're working with different frameworks and definitions in your own work and own spaces. That importance of language and that power of narrative, and how even without intention, we can often be closing down and shutting down allies that would be beneficial to us getting to goal. Next slide. I do look at this a lot in terms of framework, which is KFF. Also similarly, this is in the deck, not so much because I think there is one framework that supersedes others, but just because of the important stories I think behind this. I work so incredibly closely with Kaiser Family, KFF, formerly Kaiser Family Foundation, now in this space. I am someone obsessed with data. I'm wanting us to have more and more data to inform equity. And I think one of the realizations brought home, particularly in the last year plus, is the relevance and need for many data partners. So even from within the federal administration, we really do appreciate and utilize data that are collected by lots like Pew and Gallup and KFF. So really, I think great that that we have this framework, but also their work is super informed by their being really, really close to folks on the front line through their polling and other work. So another question too, always the origin story for frameworks, for definitions, et cetera. Next. And of course, the NIH framework and NIMHD. And one of the things I think is great about this is the ways in which NIH is continuing to evolve and push and tailor and customize this framework in particular for unique populations. I mean, one is there's an adaptation for Native Hawaiians, for example. And so, always with starting at this 30,000 view for domains, levels of influence, thinking about our health outcomes, all of this, I think, evidence of a field and discipline firmly established. I'm here, I'm sure Dr. Taylor would agree, we are standing on the shoulders of giants, many of whom have been under-recognized in the field. But here we are at a place where we are quite grounded. And with that level of establishment, I think we have the freedom now to think about how we customize and how we tailor for particular audiences. So this origin story, I think, is really important. Kind of what work are you using to guide your activities? But also, giving yourself that permission to not just take things off the shelf, but to say, let me think, is there a need to adapt or tailor? Next. Just a couple quick points here. I'm Associate Dean for Health Equity Research here. So there are a couple of things I always like to bring in the room with me. One is that health equity research is not, should exist across the translational research spectrum and across really all kinds of research. I think there is this default assumption that health equity research is something that occurs in T4 space or in health services research space only. and people don't think about it as much in early stage work, even basic science work. So understanding that what we ask and how we ask it are really critical. As I'm really happy to see the march that we're on, which is understanding that in the health equity space, we have done no one a service by focusing on deficit-based models, and that we have to be looking at assets and assets-based leverage making for change. And so thinking about ways that we don't always talk about deficits or always study deficits, right? What are risk factors? But how do we talk about protective factors, for example? And then the need to achieve bullets 1 and 2, to be really rigorous, to bring in lots of friends in the research space, the data standards, the input, and not just input of stakeholders, but the leadership, which is important. So as I try to set up work, I think a lot about the how that we do it. I think that's what unites the many researchers here at ERIC. Not that we study the same things, we certainly don't. The faculty here are amazing and do different things, but we are united in how we do that work. And so a lot of first principles around governance and decision-making, whatever the community is that's most affected, making sure that they're leading us directionally. Next slide. We can move on. I think that's one of the points is for some it's visual, but understanding that at each, in each field, each area, each phase on the translational research spectrum, that we can and should be thinking about health equity research. All right, next slide. So, a little bit about ERIC, which is like one of my favorite topics, mostly because of the people and the work. But we are organized around several of key activities for us, and mentorship you see is organized even at the top of this list. To me, there isn't another reason to be based at the academic center. We've thought about this even on occasion throughout the time that we've been founded. Should we be independent? Should we should we be a 501c3? And we always come back to the richness of the trainees here, and that would be so hard to walk away from. And so everything we do here, we almost begin with how can we engage trainees and learners in this space? How can we make sure it's a learning opportunity for those who are here in this Yale community and beyond? So also research, community engagement. So, we're here in New Haven, making sure that we are first paying attention to what's happening locally, and being really thoughtful about how we can contribute, not further prior harms, but maybe offer redress in those spaces through community engagement approaches. And then, just this team, a few folks pictured here, but we build on, I think, one another's strengths. And so making sure that that team is interdisciplinary, and that we can support a breadth and depth in this space. Next slide. So, this is some of our current activity. I won't go as deeply. From this slide, I probably will lift up our methods work. So we do think it's important to leverage different methods. I was able to author a book on mixed methods with a good colleague of mine here, Leslie Curry. So we always kind of make sure we're starting with the right methods in these questions. And then, the key around workforce development, but there are no favorite children here at ERIC. All of these cores are critically important and key to our work. Next slide. So I think the team probably thought I could share just a couple projects with where we are, and my own personal story. And I think the more that we push ourselves to be really, I think, reflective on kind of what brings us to particular research projects and questions, both in terms of revealing like where our biases are and how that might threaten the work, but also how that might enhance the work, I think is key. And so a practice I really encourage my trainees to do is sit down and kind of write an essay before beginning projects about what's bringing them to work. And for me, in this space, for the Eastern Caribbean Health Outcomes Research Network, what brings me there is that I grew up in one of the US territories. I grew up in the USVI, which sometimes when I have time, I quiz people for what the US territories are and see if folks can get to all 5. Really different places, but treated as a policy collective by the US government, particularly when it comes to healthcare financing and payment reimbursement, and having caps that are different from from states, for example. So we see differences in quality of care and other things. And I was able to lead some of that early research that shows there's difference in quality of care in the territories compared to the states. And building on that early work, we stood up this network thinking about the US territories that are in the Caribbean and placing them within their Caribbean context and being able to do a deeper dive into, for example, identifying protective factors that might be unique and might be scaled to help combat what is a global epidemic of chronic disease. So ECORN itself is this collaboration between Yale and 4 academic institutions in the region, and quite frankly, a growing number of policy partners and other stakeholders. I'm really excited because after our conversation, we're spending a couple hours with our governing board for ECORN. We're in a strategic planning process, and that brings together all our stakeholders, the people really for whom we are working in terms of community-based organizations, policies, and others. So at the core of our work is an intergenerational cohort study, including community dwelling adults and their bio-related children and grandchildren across these island sites in the US Virgin Islands, Puerto Rico, Trinidad, Tobago, and Barbados. And now there are 7 ancillary studies, and we have an implementation science core and many other components, many moving parts to ECORN, which is really exciting. Next slide. Next slide. And just to linger here, I referenced the governing board, and we have tremendous chairs, Drs. Raxter and Professor Hassel, who keep us honest and hold us accountable as researchers that we are staying true to that action-oriented mission. And so these are the chairs of our various work groups and how we organize our work in this space. It's as important, if not more so, this part of the work as it is, our data collection, which is in the cohort studies, which is, a lot of self-reported surveys and other measures of clinical assessment, lab work, and a biobank. Next slide. These are some of the projects we're working on that kind of build off of the network and take advantage of that. So whether, it's in the implementation science space, whether it's in funding new and promising investigators, in the COVID space, we're working on, in the US territories, advancing community engaged research to promote access to testing for COVID-19. In the region that's so vulnerable to climate change and natural disaster, how do we think about resiliency in our system? So it really has expanded from the first idea, which was like about a cohort study. Next slide. I will say here, this is the Radix Up Award, which is working with US territories to think about testing for COVID-19. When I was working with the governor and the Reopen Connecticut group chairing the community committee, we spent a lot of time on this question, which is when we ask people to quarantine and isolate, what are the barriers to adhering to those public health recommendations, and how can we be proactive and responsive so that those who want to adhere aren't facing structural barriers to doing so. And so we implemented a plan here in Connecticut so that we can address these social determinants, these social drivers, these health-related social needs around food, around housing, and so much more for those folks. And so bringing that model really to the US territories as well to help enhance really people's motivation to get tested, because in fact, this we know can be a deterrent to getting tested is if you get a positive or anything else, you might be asked to follow these public health practices that create a challenge for you, whether it is about not having the separate housing or it's about not having a secured income and not being able to miss work. Next slide. Next slide. I'm really proud. This is a moment for me to say I'm really proud of the other leaders here at ERIC who, in the face of COVID-19, quickly stood up a research consortium to say, what can ERIC do to contribute in a rapid response way to some of these emergent research questions. This process brought in 50 people who were not previously affiliated with ERIC at all. And the ERIC team organized everyone in these 2 research pods and set off on answering these research questions. It's yielded great insights for our own health system here as far as disparities, but also implications nationally too. And so it's great. They've been publishing and informing practice ever since. Next slide. These are the 50 folks. Next slide. And just one example of some of the work they've done around how do we think about triage scoring. We're in this place again, right? Whenever there's a crisis and limited resources, the default will be for certain people to have greater access than others, right? And so we see here that even these quote unquote objective algorithms that we think we might be using in the clinical space are not, are in fact often perpetuate bias, particularly racial bias, and disadvantaged patients of color. So we have to interrogate the algorithms, the methods that we do. You know, on the task force, which I will get to some of that work. I always said our charge to the members, in addition to the president's clear charge around recommendations, but what I add is we have to disrupt the predictability of, you know, who's harmed first and who's harmed worse, particularly when there is crisis and there is limited resources. Next slide. Next slide. You know, what I mentioned early on, if we think about kind of the cores that Eric, this, it's a core, but it's a principle, right? It's a guiding principle for us, this North Star of community responsiveness in what we do, but also really community accountability. I worry when we get into terms that we forget what they mean. And so I hear a lot health equity now, I hear a lot community engagement now, but it's important to understand that engagement, the destination is not engagement, right? And so this, I think, is really important. It's been important for me in my own training. You know, community-based participatory research was part of the fellowship program I did here at Yale, which was funded by RWJF, the Clinical Scholars Program. I continue to work really closely with the fellows in that program, and have people state out loud, right? When you seek to be in partnership with community, like identify where you are on this continuum, right? Or where you want to be. Are we showing up in this work because I have, you know, it's going to take me 2 hours, I want to run through a data collection instrument with you, which is fine as long as those expectations are shared and understood, you know, or are we here to make decisions together? We have a shared leadership model in ECORN, for example, you know, how we spend our resources, how we budget, the governing board really decides. And as long as it is aligned with what we can do under the auspices of our grants and funding, it's fine. But those grants didn't go in without consensus among the governing board participants beyond even the 5 principal investigators. And let me just take a moment now to thank the principal investigators for ECORN. There is a site investigator at each of the 4 sites and their teams, and have been extraordinary right through COVID, but certainly all along the work. Next slide. All right, so, you know, I started off by saying I'm appreciative of a chance to reflect. And I think these are some of the lessons I've learned. It has been 15 years since I finished fellowship, and have been, I suppose, a practicing health equity researcher. This is probably it, right? If you're gonna listen to something during our time together, maybe this might be helpful. And, you know, the first is a stakeholder partnered scholarship always better, right? I do not shy away from the moral arguments of why we need to be in deeper partnership, absolutely. But I refute wholeheartedly some notion that this compromises excellence or waters down our research rigor or process. In fact, I found the opposite to be true every time. You know, we put in a grant to the NIH a couple of years ago with our community partners here at Yale. Actually focused on pediatric asthma, which was the community identified top need. We wrote it together right in the conference room across from my office. Many long days. It was a great process. And when we put that grant in, it wasn't funded. And I will say, you know, whatever issues with the grant aside, I think they ended up funding 2, and one went to like Flint, Michigan in the middle of the water crisis. We could not argue the grantees selected were stellar. But, you know, when we looked at our scores, all the sections that had been written by our community partners, our community-based researchers, is often as I might refer to them, got 1s and 2s, right? So an NIH speech, that's like outstanding, job well done, like phenomenal. And then, you know, some of the sections like written by other colleagues we brought in academic spaces like didn't score as well. And so, I always share that story because no one can convince me that having stakeholder partnership in this process doesn't actually make everything better. The second is that mentors and sponsors and advisors, you will find them in the most unexpected places. So just be open, be ready. There have been people who, if you ask me, I would have sworn they were like my arch enemy, that behind closed doors, right? They were saying nothing pleasant or nice, only to discover later that these were some of the strongest sponsors I've had, and to find the converse too, right? And so folks that I always felt would take every opportunity maybe to be supportive and maybe that didn't necessarily. So I think just be slow to make judgment on like who's going to show up for you, and who can show up for you. And maybe building off that first idea, sponsors aren't just like deans and senior faculty, right? Some of my strongest sponsors are community leaders who will show up in important spaces, right? When you think about kind of being invited to be part of the governance process, right? It's community leaders and activists who sort of sponsor in that way. And so be really, really open. And I will just say as a parent, I'm fortunate because I have my own parent, my mom, who's a great advisor to me. And actually we work together very closely in the equine work. She's the PI for USBI. She's an academic nurse. And, but I would say that my children are actually great advisors too. And my spouse, like really tremendous advisors and being completely outside of the space, but knowing and understanding me and like what makes me happy and what doesn't. So really think in a broad way about that. Failure. I could do a whole conversation with you about failure, and I would be happy to, because too often what we do is have these conversations that are like, and then I succeeded at this, and then I succeeded at this other thing, and then I succeeded at something else, right? And we never talk about like, well, first I failed at this thing, and then I failed at this other thing, and then I failed really hard at something else, right? And a couple of years ago, we went through an exercise as a team of writing our failure CVs. I don't know if people have heard about this activity, but it's the CV of all the things like you tried to get and didn't, the things you applied for and didn't receive. And so we just have to norm it, I think, in a way that we haven't. Like, it's part of the process. And it's not, we shouldn't be in fear of it. What we should be in fear of is squandered time. So try to fail quickly, right? And that, I think, is been something I try to do. And I try to just don't be afraid of failing, be afraid of failing slowly, right? So try to fail fast. And then the last lesson is just the power of the team. Particularly in this moment, right, where I am in about 12 different places at every given moment. The team is what makes it, and that's part of this success narrative that is flawed as well. Like the individual stands up there and they have done all these things, and often with little, if no or any mention to the teams, right, the people who are making it all possible. So identifying talent, supporting your talent, investing in your talent, that is part of your obligation and your work. And just like the first bullet point, that's how you will make your work better. Next slide. Next one. I'll go quickly through this because, the part of this that is restorative for me is when I get to hear from you. So I want to get there. But the patient experience work we do at ERIC, and just to mention this, because back in this idea of how we can be thinking at the beginning of policy partners, in ECORN, we work with the ministries, we work with faith leaders, we work with civil society. We have a lot of partners for whom we hope our data can be useful. We don't really start work without thinking about who's going to use our data and then kind of checking and saying, does that make sense? And in our work around patient reported experiences of care, and particularly we're interested in the experience of discrimination, there are national groups like the National Quality Forum whose work it is to identify measures and metrics that that we should be using to assess quality of care. Really importantly, the Institute of Medicine, now the National Academies, said years ago, equity is one of the 6 core dimensions of quality in healthcare, but it is really the neglected one, and there are very few measures and metrics designed for that. So predicted is hopefully a contribution we're making in this space, thinking about inpatient settings at this point, but how do we get, again, the patient voice? And I've had people say, like, patients can assess quality, and again, I refute that. They most absolutely can. Next. So we've done a national work. This is formative. It's gone through multiple NIH grants and multiple stages. I often say this is the nerd work. This is a lot about item response theory and psychometric testing and other things. This is really important, and we want to get it right. Next step. So, you know, I think in the spirit of trying to, and I feel like it's always a lot in a short period of time, but in the spirit of saying, like, all the different, you know, trying to find ways to connect with each one of you, what might be of interest that's in my portfolio might be shared in yours. I'm also associate director of our cancer center here, and that role is related to community outreach and engagement and health equity research. Again, I get to work with a tremendous team over at that center in that space. Next. Through the work in the Cancer Center, we have an award from Genentech. This is a grant that we competed for from Genentech to think about our own data dashboards at the Cancer Center, how we might use data, which I always think is number one, as the tool to really benchmark us, hold ourselves accountable, but be you know, in close work with the communities that are most affected, the communities that have been harmed by data and harmed by these institutions, to say, like, what matters, and we should count what matters. So this process is not one that just says, you know, NQF, with all due respect, and I serve on NQF steering committees, not limit ourselves to metrics that have already been adjudicated, but to say, when we invite others into this space, what are measures that perhaps nobody's thought of that we should bring here that reflect what patients care about? So we have the funding from Genentech to do that, and to do that vis-a-vis cancer care and the cancer care continuum. Next slide. Next slide. I'm always recruiting, so let me be really transparent. And so it is really exciting. At ERIC, I get to work with folks who, you know, kind of are affiliated in lots of institutions and kind of stay where they are. But, you know, we have some programs that might be of interest to people. One that's pictured here is the Posen Commonwealth Fund Fellowship in Health Equity Leadership. This is a partnership we have with the School of Management here. And the Commonwealth Fund invested in us. Bob Posen has made an endowed gift, so we are supported now in perpetuity, which is really exciting, to bring in on average about 3 fellows a year who will mid-career across disciplines again. So healthcare, but this is it. Don't let me say healthcare and you think we mean like physicians or physicians and nurses, but really kind of everyone who's engaged in the work of bettering healthcare is invited to apply. So people who are mid-career and at the cusp of really transformative leadership, and how might an MBA help them? So it's an executive program. And then we layer a fellowship on top of it to give people the skills there. So really important, really exciting. The picture here is our inaugural class. They just graduated this last year. So we have first and second year fellows with us now actively. Cece, Kanitha, and Crystal, just all rock stars. Picture there with me is Howie Foreman, a good colleague of mine and a great sponsor as well. Next. And I'll go through this, even though this is what brought me into research in the first place, was really seeing we got to do better in terms of representation in the healthcare workforce. This ended up being a top line from the work in the task force. But we've just got to do better, and we need research and incentives to make that happen. Next. Next. Next, we'll move forward. Maybe it might be helpful to, this is a little bit of origin story for me, like where I started, but also, I guess this is a paper I published in 2007. The reality is, if you read it today about how race is in fact impacting the professional lives of physicians of African descent, sadly, I think a lot of it is still true. And so these are hard truths, hard realities. I'm excited to have so many people reaching out about anti-racism in their healthcare systems and other things, but the real challenge is going to be walking that talk. Next. 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 Thank you. We'll keep moving through because our time is running short. Yes. Thank you. I will briefly say this, the slides that we're going through, just so you know, Darwin Boatwright is a great colleague here, emergency medicine faculty. He was a fellow in the clinical scholars program. I was honored to be his mentor during that time. He lifted up this question around, differential access to honors and awards for medical students of color. We knew that to be true for so many things: access to NIH grants, promotion. I've written several papers about that. And what he showed in this work was that it held true as well for induction into AOA, Alpha Omega Alpha, which is the Honor Society for Medical School. And I mean, I'm a member of AOA, I was inducted. But I think it's really important that we take that lens and look again at ourselves and recognize these important things. And something like AOA membership, it has helped me professionally. And so knowing, this isn't just another honor and it doesn't matter, this helps determines people's career trajectory. So really important questions. Another, I think, use case in like asking questions that matter. AOA itself has been doing a lot of work. Some medical schools have abolished AOA at their schools as a result of this. I mean, that certainly is one way to address that bias. So just difference making work. Next. You all, okay, that program is really about undergrads here. And so I'll take 5 minutes just to walk us through some of the USG work and some of the highlights. It'll feel fast, but I'll slow down during the Q&A. I briefed the candidate and the candidates actually, right? I'm looking over here because I was at that table in my office in August 2020. When I first briefed them, I got a call 24 hours, no, that's not right. I got a call maybe 12 hours before from someone, and I didn't know them. And they said, the candidate wants a briefing on COVID-19 disparities, and can you do that? Now, these are all words I knew nothing. I didn't know who's the candidate? What's a briefing? Like these were really kind of new, and my extraordinary teams, all-nighter, to be prepared for that briefing the next day. Had opportunity to brief the candidates along the way, and then once they were elected, very honored to serve along with Drs. David Kessler and Dr. Vivek Murthy as co-chairs of their COVID-19 Transition Advisory Council. So one picture here, great scientists that we got to work with. Really, our job was to advise on the development of a national strategy for COVID-19. There wasn't one in place at the time. Just great learning for me being part of that. Writing a national strategy with the policy teams. It has 7 goals. If you haven't taken a look at it, equity is woven throughout. We do have a equity specific goal, which is goal 6, which recognizes race and place as so important in our country for determining health. Next. This is our strategy. If you ever looking for a good read, a night when you're having trouble, maybe snoozing, you could pick it up. But I think there's a lot of good gems in here. We use it. This is our Nordstar for the response and thinking ahead to preparedness for future. Next. Next. So I mentioned a couple of roles. One is a senior advisor to the White House COVID-19 response team. I'm mostly here. I'm pictured with great colleagues. We have a team of docs who advise the president. Dr. Fauci is the senior medical advisor, work really closely with that team of doctors. Jeff Zients is pictured in the center, might be the most important person in the country in terms of COVID-19, whose name you don't know. And Jeff is our coordinator. He is a counselor to the president, and he is the coordinator for the White House response and the Federal Administration response to COVID-19. Tremendous leader and a team of people working around the clock. In the upper left, I'm sorry, just quickly in the upper left, I get to be co-chair with these 4 docs of the National Public Education Campaign. And so in that work, really what I think, to the extent that I felt prepared for that role, it is the community engagement we've been doing. 5 to 7 times a week, I host roundtables with constituents. I'm in the White House. I do a lot of events, obviously, to make sure people have accurate information about COVID-19. Next. I mean, this is some of our work. If anybody's interested, we can absolutely share this slide, but it's just to say, this has been a steady march. The president and vice president have charged us to put equity at the center. And we are every time when it's PPE, testing, therapies, vaccine. So in that senior advisor role, working with colleagues to make sure that we are keep ourselves honest there. Next. People, I hope, are aware, but I think this is the notable for us. The work of so many people, equity work is always hyperlocal. So we hopefully, as the federal administration, provided the resources and the urgency, and we've played an important part. We stood up federal direct vaccination channels to supplement the work of the states through community health center partners and others, so that vaccine access would not be the issue. But here we are, like, so many of our data partners, including the CDC's national immunization surveys, have showed for consistently now since September that nationally the gap has closed in terms of race, ethnicity, and vaccination uptake for COVID-19. I'm not sure that's a statement that could be made about any other vaccine in the history of our nation. So it's remarkable, and kudos. I'm sure many of you here today have worked hard on that. Next. I'm really proud. We worked hard to get data reporting on race, ethnicity, and vaccination, and it's paid off. We didn't include the slide from the before, but let me just say reporting was very poor when the president took office, and now it's much, much, much improved. Next. So I'll take 1 minute on the task force, and I apologize because I will probably have to hop 2 minutes. I'm just getting a text for the White House, so I'm gonna hop like 2 minutes early. But the Health Equity Task Force is just tremendous, and the people on it tremendous. And I can't do it justice in the time, but everybody's showing up. Our federal staff supporting us, tremendous. We had folks who really came to the table because of the situational knowledge and expertise they have in terms of affected communities. We had ex officio members from all the agencies that are most connected to those levers for the social determinants and the social drivers, and every person committed and passionate. We worked at a pace really unheard of within 8 months to produce a report with 55 prioritized recommendations, to also include an implementation plan, key performance indicators, and accountability framework. Really, I'm so proud to be affiliated with this work. Of those recommendations. So I chair the task force as a private citizen, to be really clear, and we're independent from the government in our work. And so when we submit that report to the president, and to hear from the White House team that 80% of the recommendations the administration is already moving on, I think it's great. How often do you serve in a committee or serve in a task force when anything happens? So often it's the report on the shelf, and this is not that. So I'm really proud of the follow through on the other end too. Next. We can keep going. I just want to get to our, so this one, and then I'll stop myself, I'll pull down. But kind of, and this is good because, we're charged to think about health equity in COVID-19, what do we need to be doing and thinking, but also, again, disrupting that predictability, who's harmed first, harmed worse every time. And so there are those 55 recommendations. This task force is on our this report is on our task force website. Anybody who wants to look at it, download it, I invite you to do so. 5 things, right? Big picture takeaway. We need to invest in community-led solutions, right? The communities most affected, they're the holders to the answers and the solutions. So we have to have community leadership, and we have to be investing in that. That is not a talking point. And really, we have tried to walk this work, when I have the federal administration hat on, I've tried to walk this from the beginning. Second, data, and we have to enforce a data system that promotes equity-driven decision-making. This has been the excuse from the beginning, is we don't have the data, we don't know, we can't tell. And it's unacceptable. So many people are invisible in the data, period. It took us so long to even understand what was happening in indigenous communities with COVID-19. People with disabilities, right? Invisible, so many groups, invisible, trans people of color, right? We don't have an intersectional capacity, invisible in our data. It's a form of violence, it's unacceptable, cannot stand. The third is accountability, right? We have to row in the same direction. We have to agree on those frameworks. We have to make sure we line up our incentives. You know, people are rational actors, organizations, rational actors. We have to line up the incentives for the outcomes we want to see. Fourth, you know, investing in a representative healthcare workforce, critical. And of course, as I mentioned, you know, a pillar of work I still do, and what brought me to research in the first place was thinking about that question specifically. This is our public health workforce, our clinical workforce, you know, really expansive. We need representation there. And we need equitable access to quality healthcare for everyone. We knew that before, we know that now in time of a pandemic. And then the fifth is the infrastructure one, right, which is really about whole in this work moving forward. It's been an absolute honor for me to work with the administration, to be invited into tables and spaces I didn't think I would be in. You know, but the work has to get held, and you have to institutionalize this work, and that's true for the federal administration as it is for everywhere else. So we make a recommendation on that front. All right, take a breath. Thank you so much, Laura, for driving these slides, dealing with my hopping and skipping all over the place. Really appreciate it. But we have a few minutes for conversation and feedback. I'd be happy to be invited back at some future date too, and we'll share those slides.
Absolutely.
Thank you for this invitation.
You know, you are always welcome, and I will always invite you back. I want to recognize our provost, Dr. Dennis Mitchell, who is on with us, and thank him for his office's support for sponsoring our anti-racism speaker series. So, you know, we appreciate you and everything that your office does so that we can have, you know, wonderful people like Dr. Nunez-Smith come and speak with us. So if we have any questions from the audience, please feel free. I see.
So, Jackie, how do you want to do the questions? Do you want us to raise our hands or put it in the chat?
No, you can just speak out. I know she only has a couple minutes and then she has to run. So if you have a question, you are first.
Yeah, quick question. So Dr. Nunez-Smith, thank you so much. Ken Cato, Columbia University. Very amazing talk. Proud of everything you've done. Question, you talk a lot about kind of intentionality and thinking about how you're approaching the work. And I was just wondering if you could share from your experience and your experience with Eric, how do you deal in your organization when difficult conversations come up around folks' intentionality and how they approach the work?
Yeah, thank you. Yeah, it's a really great question. And I think it's something we all face. I think we probably could create a learning community around that, and some best strategies and other things. I think, you know, for me, I expect them. So I begin with that. I mean, there's never surprise there. I expect them, whatever the space is. And I don't really end up so much questioning people's motivations. The way that I would describe it is I probably began a career thinking so much of this was motivational. And it might be for some people, but for most, this ends up being a conversation about incentive alignment, quite frankly. And so when there are difficult conversations, my posture, again, is to invite them, you know, letting them kind of simmer is never helpful. So I really invite them. And then my posture is not a defensive one at all, right? It's an invitation to come into the space and into the work and think creatively about where that then is, right? Like, where are our incentives aligned? You know, and to bring friends like that, I think is the nature of this work. It's always we work in equity. And so, you know, it goes back to one of those principles. There are allies where we least expect them. So doing that work ahead of time is really helpful in terms of preparing for those difficult conversations that will be inevitable. So, but thank you for your kind words about the work. I get to represent it, but so many people, of course, behind it.
Any other questions from the audience?
If I may, very, very quickly, this was a fantastic presentation. Thank you so much, Dr. Nunez-Smith. One question I have is, over the last 15 years, we've seen a transition in terms of inclusive language and the language around health equity work. And I'm wondering what steps we can take to ensure that inclusive language and the way that we talk about these important topics are trickling from the way that we are talking and training our trainees all the way up through government in terms of documents being produced, information on websites, research articles, how we can really improve on some of that.
Yeah, no, thank you. It's a great observation and point. I think we celebrate the progresses when we have them. For example, I talked about the vaccine gap closing for adults in the country by race, ethnicity. There is a lot more work to do, right? This isn't true everywhere. We're trying to get to 100% of the country vaccinated. We have boosters, we have pediatric vaccination. There's always more work to do. And so having the language piece is so important. And I think that's notable, and still so much work to do. The language in and of itself is not destination, in the same way that, engagement is a reflection and a practice that gets us to goal, right? So language should be similarly. People may not be aware, the president signed an executive order on his very first full day in office. One brought the task force into being. Another one was about data for equity across the administration. And yet another one was speaking a lot to this, right? Both representation in terms of all the agencies and units taking that in self-interrogation and thinking about questions of representation, diversity, and inclusion, but also around language and access. And it's all built into our charge. So this work is already well underway for the federal administration. It's really important for our websites, our documents, and everything. But I think you're right, as a local, leader and champion with a moment to create what are best and promising practices, we have to push on this. It is one thing that I've heard consistently in all my stakeholder engagements is so often on a local level, people do not see themselves reflected in the documents that are there, whether that's language or identification. And it says a lot, right? And it really, I'll end with this, because I think all our work collectively is to demonstrate trustworthiness. We spend too much time talking about whether individuals trust or distrust us, when we need to ask ourselves if we should be trusted. And so, these are all the ways in which we communicate or don't our trustworthiness. So the time spent on, communications and is time, it's high yield and time well spent. So thank you. And again, Christina, Kenrick, thank you to everybody for all that you're doing in this space, of course, and to Dr. Taylor. Just really tremendous to be here today. And I use a lot of your work, as you well know, in our conversations too, and in the policy space. So thanks, everybody.
Well, thank you so much. It's been wonderful to have you here as always. We always learn so much from you. Every conversation I have with you, I walk away and it's always, a great feeling and a joy to just know you and the person that you are and all the wonderful work that you do for communities of color. Thank you again. It's been fantastic to have you here, and we really appreciate everything that you do.
Thank you, everybody. Back at you. Please be well.
Take care.